Thank you very much. Thank you. Thank you. Thank you very much. Bertrand, thank you for the introduction. I'd like to thank Dr. Havlir, the U.S. Chair of AIDS 2013, and Dr. Elie Katabira, thank you for your leadership as President of the International AIDS Society and the Chair here. I wish you and your successor well. I thought she gave a heck of a speech, by the way. I want to talk a little bit about where we go from here. How do we actually propose to implement these goals that have been set for 2015? If we believe there can be an AIDS-free generation, even if you define it in the narrowest possible terms, how can we achieve it? When the AIDS conference first took place in America 22 years ago, a passionate group of activists, community leaders, and researchers shouting "silence equals death" made the world listen. We then had the first ARV, a failed cancer drug called AZT. It was treating a grand total of 5,000 people, all in Europe and the United States, at prohibitively high cost. That's a long way from where we are today with 8 million people on treatment around the world and the ability to treat all the rest who need it. Back then, AIDS was the death sentence, and those of us who are old enough to have been fully grown then still have lots of painful memories of our friends who did not survive. Then we couldn't really imagine an end to the epidemic. Now all of you have created the possibility that we could have an AIDS-free generation. As Bill Gates said, we still have a good ways to go, but we have come a long way. Everything I say today comes from the perspective of the work my foundation has done in the last 10 years. Before the Global Fund was funded, before there was any PEPFAR, our job was to go around and raise money country by country to figure out how to cut costs and to provide a working delivery system that would save lives. Now think about the commitments made here and by people throughout the world to achieve universal access, to eliminate mother-to-child transmission, and to cut new infections in half by 2015. We can do that, but it won't be easy. Just last week, on my annual trip to Africa to look at our programs, I visited Uganda, Mozambique, South Africa, and Rwanda. I saw amazing progress. I saw leaders committed to offer treatment to anyone in need. I saw a willingness to completely eliminate mother-to-child transmission. Then I met with program managers who don't know where the money will come from and aren't sure we yet have the systems to do that. To achieve universal access by 2015, we'll have to increase the number of new people on treatment by 30% a year. For example, in 2005, there were only 10,000 children on treatment in low-income countries. Thanks to many of you in this room, and a special thanks to Unitate for stepping into the gap, the global effort to accelerate pediatric treatment means there are 500,000 kids on treatment today. But to reach the goal, we'll have to have 1.5 million more. To eliminate mother-to-child transmission, we need to test and treat women earlier and keep them on the treatment longer throughout the entire period of breastfeeding when many of them live miles and miles and miles from the place where they get their medicine today. To cut new investments in half, we'll have to heed Julio Montaner's years of pleas to implement treatment as prevention and implement combination prevention programs. Now, we can save a lot of lives if all this is done, but we're going to have to do it together, to do what works, to spend the money we do have with maximum impact, and to raise what we'll still need. It's worth remembering, and I don't think enough has been made of this, that of the $16.8 billion now being invested annually in this effort, for the first time in my memory anyway, more than half of it comes from the affected countries themselves, and they deserve an enormous amount of credit for that. One of the reasons universal access is achievable is we can do it for less money than previously thought. My foundation recently released the results of a costing study that we did with 5 African governments across more than 160 treatment facilities in Ethiopia, Malawi, Rwanda, Zambia, and South Africa. I thank the leaders of these countries and all the healthcare personnel for taking the epidemic seriously and for the progress they've already made in scaling up the programs. The study was the largest of its kind. It shows that with the exception of South Africa, where labor and lab costs are higher, treatment costs an average of just $200 per patient per year. That includes the cost of drugs, diagnostic tests, personnel, and outpatient costs. There is no excuse for failing to provide treatment to the remaining 10 million people in need. Even in South Africa, there are real opportunities with the commitments the government has already made. Our foundation recently redid the drug tender for them, and last year and this year, in just 2 years, they saved $700 million on what they were spending for drugs, and immediately added 340,000 people to the treatment rolls. More savings are on the way. Tenofovir's price has dropped 70% since 2008, 30% since last year. It's $125 now, and it's a good drug. The savings of that drug alone by 2015 will be $500 million. We can use that money in this fight. Now, I have to be fully candid. Meeting the goals of treatment by 2015 will require some activities, especially community programs, that weren't involved in the study. You've got to have community outreach workers if you want to get mother-to-child transmission down to 0. You just have to do it. We can't do it without it. But clearly, just what I've already said should convince you that we can meet the treatment goals. And we should. We also know that smart investments save money. The United States Center for Disease Control presented an economic model this week suggesting that implementing a test and treat strategy for key populations like pregnant women and people with TB and accelerating the scale up for others will not only save lives and avert new infections, it will actually lower costs within just 5 years. Where will we find the money? We all know that last December the Global Fund had to postpone the funding round because it was short on cash. But the fund is now back in business because the Gates Foundation, Japan, and Saudi Arabia stepped up on the heels of President Obama fulfilling America's 3-year commitment. Secretary Clinton recently announced here more money for the U.S. to meet the 2015 goals. And I'm hopeful that other donors will do the same, especially big countries that are growing fast, like China and Brazil. And don't forget, as Elton John's presence here and Bill Gates' presence here reminds us, there's an enormous amount of private money being raised and spent, and there will be more. From the Gates Foundation, Elma, Elton John, AIDS Life in Vienna, the Dutch Postcode Lottery, MacAid, SAN, and many others. And governments, even in this difficult time, I believe will do more if we prove we're maximizing the impact of the money they have given us. The United Kingdom has followed a strict austerity program without cutting its development assistance. An astonishing fact. Our foundation works with them, with the Irish, the Norwegians, the Swedes, the government of Australia, all of whom are giving and giving, even in this difficult time. And finally, we need to make something good out of what is otherwise a not particularly wholesome development, the growing inequality of income in wealthy countries. Thank God a lot of wealthy people want to give more and would give it to this cause if they knew what an enormous impact their dollars can have. Do not minimize the possibility that we will have more private giving as we make more progress and demonstrate it. I also think that we can learn a great deal from Unitate, which has led the way in creating a new revenue stream that has saved hundreds of thousands of lives, just in my experience, from what it's done in putting children's ARVs and second-line ARVs out there at more affordable prices, leveraging short-term investments for long-term gain. We need more innovative financing. The International Finance Facility for Immunizations may offer a good model for us. It raises money by issuing bonds in the capital markets, which are backed by long-term commitments from donors, so the donors can buy now but pay later, increasing aid flows over a 5 to 7 year period and then paying them back over a 20-year period, as we all know now, at low interest. Applying this model to raise funds to implement accelerated treatment, combination prevention, would mean that infections and costs will be lower when the time comes to pay the money back. If we all keep producing results, I believe the money will be there. And I am committed to doing whatever I can to see that it does. We do have to prove over and over again that we're making the most of the money. We have managed to lower treatment costs at the facility level from what UNAIDS said in 2003 was about $1,000 a person a year to $200 today. And beyond that, further cost reductions are coming. Looking ahead, there are some other things that I think we should do. First, we can target the money we're spending more effectively, especially in prevention. UNAIDS recently reported that in 2 African countries where 30% of new infections were driven by high-risk populations, less than 1% of the prevention dollars were spent to reach those people most in need of services. We can do better than that. Last year, UNAIDS published an investment framework providing guidance on how to prioritize national strategies, to focus on the interventions that have greatest impact. It's an excellent tool that I'd like to see more countries adopt. Secondly, and this may be somewhat controversial, but I feel strongly about it, we need a new level of openness about how every last dollar is spent by countries, by donors, by NGOs. You can't expect program managers all over the world to make the smartest decisions if they're trapped in a financial black box. all donors, all nations, all NGOs, I believe, should make our spending records open and available, not so somebody can be embarrassed, so we can see who's doing better and the rest of us can copy. We have to work together. If we do this, you know as well as I do, everybody that's been out there working, we can have a much bigger impact with the dollars that we have. Thirdly, I think we need investments based on evidence, not the politics and vested interests that too often drive spending decisions. We're all going to meet these goals, we're going to have the courage not only to start and scale up things we need to do, but to shut down programs that aren't working, and to channel more money toward the populations that are driving the epidemic and the evidence-based interventions that are working. And finally, we got to make sure that we're paying for services that directly help the people involved. When businesses start operations in new countries, they often send in their people, expatriates, to help get the work off the ground. But then management responsibility is transferred to national leadership. I think we've reached a point in the HIV response where we have to do more of that, to transfer more responsibility to national governments and to local NGOs. I don't want to imply that I think spending on international organizations can go to zero. That's just not true. Many countries still need support to grow and sustain their progress and to build the infrastructure necessary to run their own health programs effectively. But international technical assistance can be very expensive. Some organizations pay consultants up to $600 a day. For the cost of a day of consulting, we could put 3 people on treatment for a year. That means every time we make the former rather than the latter choice, we have got to know what we're doing and be prepared to defend it in the light of day. Otherwise, we should go for the life-saving. Let me say that I think channeling more money to capable governments is catching on because it will save money and because it will build capacity and produce sustainable results in the countries that need them. PEPFAR has recently announced its intention to transition greater ownership over its funds to national governments. I am very grateful for that. And just last week, when I was in Rwanda, the national government and the health minister, I believe, is here today, announced a new effort to dramatically reduce overheads in training the entire healthcare workforce of the country. I applaud these efforts, and I think more of this can, should, and must be done around the world. Now, having said that, we all know that money's not the only impediment to meeting our goals. 2 years ago in Vienna, we heard about the promise of combination prevention. We heard about the evidence of treatment as prevention. We agreed about the impact of male circumcision and accelerated action in that area. We heard about promising ways to improve the effectiveness of treatment, including increasing point-of-care technology, something our foundation has been involved in. We didn't really know how to implement these programs at scale, but at least I, and I think most of you, left Vienna willing to act, eager to act, and newly energized. 2 years later, there's been a lot of progress, though none of these proposals have been taken to scale. Many hard questions remain, and we could spend a lot of time talking about the hard questions. How do you find people earlier before they feel sick? How do you ensure people get the information they need to make their own decisions? How can we improve retention and care? What treatments as prevention are best, and if we do it, and if we do even more circumcision, will it really lead people to give up less costly and proven effective ways of prevention that they were previously observing? All these questions are important. But should any of them be a bar to doing what we know we have to do? I would argue no. I remember well back in 2003 when Jim Kim launched the 3x5 initiative. There were lots of serious questions about whether we could meet the goals of increased treatment. There were people who even said, since we can't treat everybody who needs it, how will we decide who gets it and who doesn't? And wouldn't we be better off, because it's so much cheaper, just doing universal prevention efforts? But guess what? We responded to Jim Kim's challenge, and now there are 8 million people on treatment. That's the way we have to respond to these challenges. Sometimes you have to make a commitment before you know how you're going to get there. China, Rwanda, and Swaziland have all announced their intent to implement treatment as prevention at scale. We are working with the government of Swaziland and our foundation. The prevalence is about 26%. I've been really impressed by the leadership and foresight there. They know this is the only way they're going to achieve their goals, and they're focused, therefore, on how to do it, not whether to do it. Malawi is a country with very severe resource constraints, where I also have the honor of doing a lot of economic work. They made the decision to put all pregnant women on treatment immediately for life. They didn't wait to figure out how to do it or how they were going to pay for it. They made a commitment, and I believe President Banda showed wisdom and strength in doing it, and we should all be grateful to her, because now every one of you can say, if Malawi isn't waiting, how can the rest of us wait? You may think this is naive, but I've seen it happen over and over again. This is one of those, if we build it, they will come. If you scale it up and it works, the money will be there to fund it. We also talked in Vienna a lot about improving treatment that works, identifying the patients earlier, reaching them where they live, treating diseases that really kill people like TB and cryptococcal meningitis. Today we know about the best practices from groups like Partners in Health, Mothers to Mothers, and MSF. We know about the importance of decentralizing services, empowering community members. We know from pilots in Mozambique, Malawi, and Zimbabwe that if we provide CD4 testing at the point of care, we can cut pre-ART loss to follow-up in half. We know that if nurses play a larger role in caring for patients, including initiating treatment, we'll reach more people in an environment where they feel better understood and cared for. So when we scale up, we will stop just paying lip service to community engagement, and we'll have to start engaging and relying on communities. These are things that I believe. I think the money will be there if we prove that we're responsible with the money we've got, and if we prove that these approaches work. You have nowhere near tapped the universe of people who will invest in meeting these 2015 goals and creating an AIDS-free generation. We just have to keep pushing the rocks up the hill. Speaking of rocks up the hill, since we're in our nation's capital, where the prevalence among some groups is as high as it is in countries in Southern Africa, I'd like to just say a couple of words about that. We have about 1.2 million people in America living with HIV. Barely more than a quarter of them are getting optimum care. Infection rates are rising among young gay men and exploding among young black gay men. Latinos, Native Americans, Asian Americans, and Pacific Islanders, you saw some of them go by. Many of them feel that because of the overall progress made in the fight against AIDS, they're just going to be left out and left behind. But in this city, government and community leadership has been reinvigorated around community viral load testing and test and treat strategies. They are making a difference. Since 2007, there has been a threefold increase in the number of people being tested every year, a tenfold increase in the number of condoms being distributed every year, 300,000 clean needles provided every year, and 90% of the people who test HIV positive in Washington, D.C. see a doctor within 3 days. President Obama's administration was the first to develop a comprehensive strategy for the domestic epidemic. The Affordable Care Act, which, thank God, the Supreme Court upheld, will provide coverage to people who will be helped. The funding that he and Secretary Sebelius committed this week to close the ADAP waiting list is very important. And I want to just emphasize something else that in the context of the United States can be huge. You all know that when I do processing work around the world, when our foundation does, we use generic drugs. And they've made a huge difference. Yes. And PEPFAR money can now be used to buy those drugs. First, because Eric Goolsbee and all the people at PEPFAR agreed that they should. And second, because I made an agreement with President Bush when he was in office that I would submit all of the medicine we send anywhere in the world to the FDA. And he said if the FDA approved them as being effective and appropriate, that any local country could use their money from PEPFAR to buy that medicine. And and he kept his word. And that was the beginning of this. And I'm very, very grateful for that. But that means that in America, where these drugs are not available, we got to do something for people without insurance who can't afford the drugs. So, our foundation has partnered with HarborPath, NASTAD, and major pharmaceutical companies to make access to affordable HIV medications available faster, in a simpler way, on a longer-term basis for people who don't qualify for ADAP but can't afford the drugs. Here's the idea. HarborPath will provide a one-stop shop for uninsured patients to access all the patient assistance programs available. The program will simplify the paperwork and cut through red tape. And I want to thank ViiV Pharmaceuticals and Merck, who have already stepped up to support HarborPath with steeply discounted medicines, and I hope all other manufacturers of HIV medications will soon follow suit. One more word about the United States. Besides D.C., the next biggest problem we have with AIDS is in the American South, where I'm sad to say, since it's my home region, there's still too much stigma. Stigma against men who have sex with men, against sex workers, against people who are drug users, where this is not treated enough as a public health problem. And that, plus the poverty, plus the disproportionately high percentage of people in our country in the South who live in rural areas and therefore have some of the same exact access problems that people in Africa and Southeast Asia and other places have created a big problem for us. I just wanted to say two things. It's embarrassing to me to think that stigma against people with HIV exists anywhere in America. It's still a problem in other places around the world. But look at the numbers that came out just this week. Yes, it's true that 56% of the people who need medicine now to stay alive are getting it. But look at the numbers in the area where there's more stigma. In Central and Eastern Europe, way less than that. In the Middle East and North Africa, even less than that. Not even 25% in the latter, barely a third in the former. So we, all of us, can't be blind to the fact that no matter how much we come together and cheer each other and see the evidence, that we still have to fight stigma wherever we find it and support our friends and neighbors who are doing that. And we also have to deal with the fact that not everybody treats these drug problems the way Washington, D.C. and a lot of nations do, as a public health issue. The great Dr. Mathilda Krim and Ethan Nadelman had an amazing article just a couple of days ago documenting the death rate from AIDS that has come as a direct consequence of the refusal to see drug-related infections as a public health problem as opposed to a criminal justice problem. So we have to deal with it. I think, for me anyway, thinking about where we were in 2002 when Nelson Mandela and I went to the AIDS conference in Barcelona, and we were literally rattling a tin cup for money. By the way, I just was with him on his 94th birthday, and I told him I was coming here, and he said, "I am retired, but tell them I wish them well." But I think you should be excited about this. I know you're worried about the money and a bunch of this other stuff. You should be really excited about this moment because you're committed to work through the financial crisis, to go beyond incrementalism, to embrace profoundly ambitious goals for 2015. I've been asked actually to work, thanks to the AIDS Life group in Austria with a couple of African countries, to figure out how you actually would take mother-to-child transmission to zero, because they know it's way more than just getting the medicine out there. But it's exciting, and we will do well as long as we refuse to let what we don't have slow us down. We have to use what we do have to get the programs off the ground, and we'll answer the questions as we go along. We've got stronger leadership from every sector than I can remember. The research community is still laboring away toward the dreams of a vaccine and a cure. More and more people from the private sector bringing their business acumen to the financial questions. Civil society still pushing us all to do the right thing. Communities in America, from Anacostia and Oakland to Mumbai and Sao Paulo to St. Petersburg and Kiev, Lilongwe and Kigali. All of them taking responsibility for their children and their future. They have not gotten enough credit, the developing world and the middle-income countries, for spending even more money than the donor countries and the individuals are doing to fight this epidemic. They are worth our supporting if they are coming up with this money, if that's what it takes. This is serious. I've been doing this a long time. All this has really happened because of you and the people who sat in these chairs at every previous AIDS conference going back to the beginning. Millions of people and an AIDS-free generation still depend on your daily tenacity and courage. No, we don't have all the money or all the answers we need. but we have you. We have you to thank for the progress that's been made, and you to make us believe we can achieve an AIDS-free generation. And all over the world, in places where we work, you have millions of people nourishing their dreams and their children's dreams instead of giving up. It's worth a lot. We have to deliver for them. Thank you, good luck, and God bless you all.